Hello, my name is Dr. Danielle Kauffman, and I am a senior pharmacy consultant at ARUP Laboratories. My background is as a pharmacist in a hospital pharmacy with a focus on informatics and financial management. My role at ARUP is to make connections between lab and pharmacy practice. We will be talking about harnessing the power of pharmacy-lab collaborations and also the benefits of multidisciplinary teamwork on budgets, workflow, and population health. There will be two sections to my discussion. First is some general information about pharmacy and laboratory interactions and collaboration opportunities. The second section will be focused around population health and how pharmacy and lab are at the center of many of these initiatives, and then also specifically on how precision medicine fits into this topic. Pharmacy and lab interact every day, whether intentionally or incidentally. Providers are not the only ones putting orders in the electronic health record. Pharmacists also order drugs and labs according to hospital protocols. The pharmacy needs results from the lab in order to determine that patient therapy is effective. One common example of this interplay is for the ordering of antibiotics such as vancomycin. The drug requires a therapeutic drug concentration order from the lab so that the result can be received to make sure that the vancomycin stays at the correct concentration in the patient's system to take care of the bacteria that are in place. The laboratory also provides a culture and sensitivity test so the pharmacists know that the vancomycin is the drug that is most beneficial for the patient condition. Another but less common example is infliximab or brand name Remicade. Many pharmacists and providers do not know that there are drug concentration and neutralizing antibody tests to help with this drug. Lab has the perfect opportunity to reach out with this information and let them know that these lab values are available for therapeutic drug monitoring. These tests and that there are potential for cost savings through the monitoring of these tests because therapeutic drug monitoring has been shown to be more cost effective than traditional trial and error dosing. The neutralizing antibodies actually show that if the drug is going to be effective in the patient. If the patient is producing antibodies, then the provider will know that it would be better to switch that patient to a different drug. So you can see from these examples that the pharmacy and the lab have many interactions all day long. For budget planning, every year, the pharmacy and the lab are asked to present their budgets for the following year. Traditionally, both departments have worked in silos. They have their own department-specific goals and metrics that they are following. So lab knows what lab tests are being ordered and what tests are available in-house or from reference labs. Likewise, pharmacy knows what drugs are being ordered on a daily basis and which of these drugs require lab monitoring. They also know what new drugs there will be out on the market in the upcoming year and budget accordingly for those. However, both departments would benefit greatly from each other's knowledge for even better budget planning. If the pharmacy knows that a new drug is coming out to market and there's a new lab test that has not been done up until now, they should reach out to the lab and ask the lab if this test is available in-house or if it's something that will need to get sent to a reference lab and if that's an exorbitant expense. If it is, perhaps the lab and pharmacy could work together to guide providers towards a different drug that would be equally effective but less expensive for the treatment of the patient. It is also very important for the hospital administration to understand this interplay. If we go back to the example of infliximab, when the pharmacy is introduced to the fact that there is a lab test, more lab tests will be ordered, which means there's a greater expense being seen in the lab. However, for a few $100s for that test, there's a potential of saving thousands of dollars on the drug expense in the pharmacy because that drug costs about many thousands of dollars per dose. So if the hospital administration understands that a little bit of an increase in lab means an even greater decrease in the pharmacy, they will understand that overall for the hospital expenses, that is an overall decrease. So the lab cannot drive hospital savings alone, but pharmacy drug expenses are huge, and by reaching out to pharmacy, a few extra lab tests could mean large savings for the pharmacy and then for the hospital overall. Another example of a potential collaboration opportunity is with shared workflows. And this is an example that comes with a story. The story starts with another department, and that's nursing. So one day when I was sitting in the pharmacy, nursing came in, and they were very tired and they were exacerbated, and they said, you know, we're really tired. We run back and forth between the drug dispensing cabinet and the patient just about every half hour to dispense to administer a medication. Isn't there anything that you could do to help us with the administration times to, you know, group these administrations more around standard hours of the day? So we looked in the system, and we understood how this could be a problem, but we weren't exactly sure what was causing the problem. So we looked into the electronic health records to see what kind of default orders were built in the system, and that we noticed that the great majority of drugs were built with interval dosing, so strict every 8-hour, every 12-hour types of scheduling. So if you schedule one drug starting now for one patient, strictly 8 hours later is when the next dose is due. And if a second patient comes in with a similar dosing schedule in an hour, their next dose is an hour off from that first patient. So this could be multiplied in complexity all throughout the hospital. So what we did was we went right to the source, and we found that the majority of drugs really could be ordered with more standardized dosing, and that's with, you know, BID or TID dosing, which those doses in the computer are built with specific times. So naturally, as drugs are ordered, they're positioned more around standard times, like 9 o'clock a.m., 9 o'clock p.m., and then it schedules the drugs a little bit more standardly. And we noticed that when the orders started coming through this way, the nurse's schedule lightened up a lot more. It also helped the pharmacy because there were less drug deliveries that had to be made. And we noticed that it also helped lab as well. Back to the vancomycin example, those trough concentrations need to be drawn by the lab on specific schedules prior to the next dose. So if the administration times are standard, then the lab draws are also standard. So that's one way that you can help standardize workflows among the departments. And it's not a strict cost savings, but it is time savings, and time is money. So each department can spend time back in their departments doing other clinical activities and more time at the bedside for the nurse. The second section now is population health, and we'll talk about pharmacy and lab collaboration opportunities in surrounding regions. So first, to talk about a few definitions related to population health, note the words that are colored in bold because we'll make some comparisons to the next slide. But population health is the analysis of data into a single actionable patient record, and then its actions through which care providers can improve both clinical and financial outcomes. Population health talks about improving health outcomes of a group by monitoring and identifying individual patients in that group. It includes surveillance, managing risk factors, monitoring of drug side effects, quality of life, and preventative services. And these definitions are important because healthcare organizations are being increasingly asked to make sure that the health of those in their community are benefited from the services they provide. On the next slide, we'll go through some of the definitions of precision medicine, and again note the words that are bolded in relation to the previous slide. So precision medicine is an emerging approach for disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle for each person. It talks about improving the health outcomes of the community by customizing care for the individual. So again, that treating the individual, which benefits the outcomes of the group. So it allows, precision medicine allows practitioners to target patient response to prescription drugs, and it helps to prevent adverse effects and prevent readmissions. So you're looking at increased care and decreased expenses. Here on this slide, just a couple of definitions. Pharmacogenetics and pharmacogenomics are terms that you'll find used interchangeably, and that's fine, but there is a slight difference between the two words. Pharmacogenetics refers to one gene and one drug and the interaction between the two. Pharmacogenomics is a little bit broader definition, and it refers to a group of genes and drugs that combined affect each other. On the next slide, this is talking about the opioid epidemic, and this is a specific example of how precision medicine benefits population health. I'm sure you are all well aware of this epidemic, so I will not read through these numbers, but the main point here are the opioid overdoses and overdose death related to that. Some of these drugs have pharmacogenetic variants that affect their metabolism. If the drug is not inactivated and cleared from the body, the patient could eventually overdose from simply taking their normal doses. This is not the whole problem, but it could definitely be some of the problem, and using pharmacogenetics is a way to benefit and improve this epidemic. Some considerations for precision medicine are listed here. Precision medicine provides personalized care. Now we know that one-size drug does not fit all, and patients want to be treated as individuals. There is also a growing public awareness and focus on genes. Ancestry.com, 23andMe are being used because people are very curious about their genes. They have an interest, and they're also realizing that there is a potential for using the knowledge of these genes for better health. They take these reports often to their medical doctor already and ask their doctors to treat them as individuals and individualize their therapy according to their genetic makeup. So people are also taking a greater role in their own health care. They're taking those records to their providers and potentially even changing their lifestyle because of them. Precision medicine is also a great chance for collaborative stewardship. It allows you to focus on patient care and also your budgets, because there is a cost savings for the patient and healthcare entities using more targeted therapies. And then remember individual department expense versus comprehensive hospital expense. So again, there will be some extra lab tests to be able to test for these genetic variants. However, there's a great potential for more efficient use of the drugs, resulting in cost savings and just better, more efficient use of drug therapy. So there's also improved therapy and monitoring. Precision medicine allows you to achieve a therapeutic drug and dose combination more quickly. It also helps to minimize toxicity and increase efficacy. For a little bit about drug metabolism, traditional dosing is based on an average drug response for a population. But in reality, there is a huge variability in metabolism and response among individuals. The risk here with traditional dosing is the fact that 7 million emergency department visits happen per year due to adverse drug events at a cost of $3.5 billion. Some of these adverse drug events can be due to incorrect drugs or doses that could have been better managed through individualized therapy and precision medicine. Some of the sources of variation are the pharmacogenetics. The CYP enzyme phenotypes are where there is a lot of variation, and CYP enzyme just refers to the cytochrome P450 enzymes, which are the group of genes and enzymes that metabolize drugs. So some of the individual genes would be called CYP2C19 or CYP2D6, so it's the name of the gene itself. So people can range anywhere from being poor metabolizers of genes to ultra-rapid metabolizers of genes. So some people clear drugs more quickly and some clear them more slowly. So that's why there could be an effect on adverse drug events or inefficacy if the drug is not staying in the system as long as it should. And in fact, over 90% of the population have at least one genetic variant according to studies. So don't forget also, it's not all about pharmacogenetics. Concomitant drug therapy is also still important. Drug-drug interactions need to still be monitored. And actually the reason for drug-drug interactions are because of the gene. Two drugs are metabolized by the same gene, and one may induce or inhibit the metabolism of the other drugs. So pharmacists really have been dealing with genes for many years. It's just that pharmacogenetics now is a new level of monitoring. Environmental factors are also still important. Things like diet and smoking and exercise affect metabolism. And then disease states also need to be taken into account. If a patient has liver disease, that is a problem for all drug metabolizing enzymes that are located in the liver. So another important point to make is that you will never know some drugs are not working until they fail. And listed here is an FDA, or Federal Food and Drug Administration, black box warning. This is their highest level of warning that they place in drug labeling, and the FDA requires this on the drug label. This drug warning here is for Plavix, or generic name clopidogrel, which is used to prevent strokes. Plavix is a prodrug. That means it's inactive and does not do anything until the patient metabolizes it and activates it through the CYP2C19 enzyme. However, poor metabolizers do not activate the drug properly, and so they are not actually protected by this quote-unquote standard therapy. So you can see here that the black box warning speaks to this. It even mentions that tests are available. So there should be no confusion as to whether tests are available and ready for testing, because the FDA wants to make sure that people know that testing is available. And the FDA says to please consider the use of another platelet inhibitor in patients identified as poor metabolizers. And black box warnings actually show up on about 8 drugs, and genetics are mentioned in over 150 drug labels now as far as their effect on the drug metabolism. So finally, pharmacy and lab are better together. When they work together, this benefits the entire health system. It improves population health, and together lab and pharmacy can employ precision medicine effectively and efficiently for the benefit of the healthcare system and those in their community.